Okay, good morning, everybody. Welcome to today's webinar. My name is Professor Paul Tipton. I'm a specialist in prosthodontics. I'm Professor of Cosmetic and Restorative Dentistry at the City of London Dental School in the UK. I'm also President of the British Academy of Restorative Dentistry and Director of Tipton Training. So today, we are going to be looking at the treatment planning options for a missing single tooth, and especially looking at not only the science, but also some clinical situations and some clinical studies. So in terms of the missing tooth, and today we're going to focus on the anterior missing tooth. We've got four options, okay? Four options for its replacement. And in no particular order, we have partial denture, adhesive bridge, conventional bridge, and then implant. So its replacement, what does it depend upon? For me, there are many variables, obviously, but the major three that it depends upon is longevity. And this is when we're talking to our patients. So we're talking to our patients about a missing tooth or a tooth to be extracted, soon to be missing. And for me, there are three major aspects which I need to talk to my patient about. My patient needs to understand the longevity of each of the options for treatment. Next thing, we need to look at the conservation, tooth conservation, in terms of, are we taking a lot of tooth tissue away? Are we taking no tooth tissue away? And finally, we also need to look at the aesthetics of the case. What is going to give us our best aesthetics? Now, most of the time, it's impossible to fulfill all three criteria. And a lot of the time we have to go and do what is the best, choose two criteria for success. But let's look at all the variables and bear in mind these three aspects that we're going to be looking at as we go through. So for treatment planning our missing anterior tooth, the first one that we can look at is the partial denture. So what do we know about replacement with a partial denture? Obviously, not many patients enjoy wearing a partial denture, number one. However, in terms of the predictability of the aesthetics, if we're looking at aesthetics here, then a partial denture is probably the most predictable, and I say predictable here, the most predictable replacement of a single missing tooth. Why? Number one, there's no surgery involved. If you put an implant in the surgery, there is risk of bone loss and soft tissue loss. Number two, we don't need to prepare teeth either side. And if we prepare teeth either side, depending on the quality of the technician that we use, we can either get a very good looking aesthetic result or potentially something that looks as though it's false. Number three, we have got really good composite, hard impact acrylic teeth now, which look absolutely beautiful. Number four, we can replace any of soft tissue defects easily with some pink acrylics. So in terms of aesthetics, if this is your major demand, do not dismiss the partial denture. And in terms of the predictability, if we look down this same paper by Priest, where he looked at predictable outcomes aesthetically for the replacement of missing teeth, partial denture came top, implant came bottom, and we'll look at why a little bit later in this presentation. And remember, I keep saying we're focusing on predictability here. Second was the adhesive bridge, because it meant that we did not cut down labial surfaces on the teeth either side. And yes, there is the problem of graying of the incisal edge. We'll look at that. And in third place was the conventional bridge. So let's start to turn our attention now to the adhesive bridge. And what we're going to focus on first of all is, of course, longevity and success rates. And we've got these three aspects that we're going to look at: longevity, tooth conservation, and aesthetics. So from a longevity point of view, Peterson did a really nice study, 5-year study, where he looked at the longevity of adhesive bridge work versus conventional bridge work versus single tooth implants. And you're going to see parts of this study as we go along. So 5-year survival rates of adhesive bridge work, 87%. So that looks very, very good. And this is from 2008. What else do we know in terms of the science? And again, we have this problem of unpredictable results. Priest showed us in 1996 that our success rates were as good as 90% success rate over 11 years to 46% success rate over 11 months. So this is highly unpredictable. And we have to, if we're going to do adhesive bridge work, we have to understand better why adhesive bridges succeed and why they fail. And it is not just a matter of sticking a metal wing on an abutment. We have to look at some of the basic design criteria for any sort of bridge work. I'd like to remind you at this stage that if you are doing bridge work, an adhesive bridge should not realistically be something that you talk about. You should talk about bridge work, and an adhesive bridge just means that one or more of the retainers happens to be an adhesive retainer, just like a full crown will be a retainer. So when you're understanding bridge work and understand bridge design, please understand the concept that we design bridges from front to back, first of all. Anterior bridges designed first, posterior bridges designed second. The second thing we do is we look and decide upon our abutments. Okay, at the moment, no mention of adhesive versus conventional. We look at the abutments and the suitability for the abutments. Are the abutments healthy? Do the abutments have large amounts of bone loss? Do the abutments, are the abutments root filled? Do they have areas on them? So the quality of the abutments comes second. Third is the design. And the design is then, is it fixed movable? Is it fixed? Is it cantilever? Or is it some of the more advanced options, such as coping bridges or Linder and Nyman periodontal prosthesis? The fourth part, the final part in the design criteria is then choosing the retainer type. The retainer type can be a full crown, 7/8 crown, 3/4 crown, gold onlay, gold inlay, post crown, adhesive metal wing. Okay, so it is only a retainer. So when we talk to our patients, I know a lot of us talk to our patients, you can have an adhesive bridge or a conventional bridge. If we understand bridge design properly, we should just be talking about we can do a bridge for you. And then the conversation will move on to how important longevity is, tooth conservation is, aesthetic is. And then we can choose our retainer types. Makes much more common sense. So we have these unpredictable results because we are using incorrect bridge design. Here, we've had double abutting, and double abutting is usually an absolute no unless we have multiple teeth that are mobile. Here, we've got Maryland wings linked in a fixed bridge with conventional full crown retainers. Again, people not understanding bridge design. So what do we know generally about bridge design, success rate, success criteria for adhesive bridges? So we'll have a number of studies here. First of all, we have maxillaries work better than mandibulars. Okay, anteriors work better than posteriors. So why is that? First of all, if you think about it, tapping up and down, then you bite on the palatal aspects of an upper, therefore the cement lute, the adhesive cement lute, which is the part that will break down the quickest, that is under compressive load, so less likely to fail. Do exactly the same thing, bite up and down, and it's a lower Maryland, and you now bite on the pontic. That pontic is being pushed downwards, and therefore the cement lute is now under shear. This brings us to one of the success criteria for Maryland's adhesive bridge work is tooth preparation. And we tend to do more tooth preparation on a posterior than an anterior, more tooth preparation on a mandibular rather than a maxillary. because the cement lute is under a different type of force. And here you see the conventional situation. I'm sure you've seen this many, many times, where the bridge design has been done incorrectly and a fixed anterior bridge has been done rather than the fixed cantilever. If this was a conventional crown, 3/4 crown, whatever it was, we would still have the same design, which is at the front of the mouth, unless we have mobility and unless there's any other major problems, then it will be a single cantilever. And adhesive bridge work does not work in these situations very well unless the abutments are mobile. And the reason being that we're now taking the periodontal ligament out of play. When we do fixed bridge work, teeth have individual mobility. And as soon as we splint them together, that mobility is reduced or eliminated. We have to understand the periodontal ligament is our friend. Mobility is our friend. Mobility is a stress breaker. And by stress breaker, we mean that mobility will take the stress away from, number one, the cement lute. Less cementation failure, very important with Maryland adhesive bridge work. Number two, the ceramic or porcelain. If there's less stress on it, therefore there's less chance of it chipping, another mode of failure. Number three, the abutment tooth. And there's less chance of the abutment tooth fracturing off at gum level if we have the periodontal ligament in place. So mobility is a stress breaker, use it. Now in this situation on the left-hand side, you've seen this very often, I'm sure. We've got a failing Maryland bridge. It's a fixed bridge. It's been on and off many, many times. Bits of it have broken away. Why is it failing? Well, let's look at this tooth, the central incisor. This tooth wants to move forwards and backwards in this direction. The lateral incisor doesn't want to move in that direction. It wants to move in this direction. The central incisor doesn't want to move in that direction. It wants to move there. So basically the periodontal ligament and the mobility has been taken out of play. Now what happens? Okay, let's look at the occlusion. So we have a lower tooth. Let's say our lower tooth is contacting here. And we slide up the metal wing. And when we get to the junction between metal and tooth, we go clonk, bang. And we go up and down at nighttime. Imagine I'm bruxing on this at nighttime. Probably 20% of your patients are going to be bruxing on your restorations tonight. So we go up and down and we keep on going from metal to tooth and we go bang, 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 bang. And because there's no mobility there, we get concentration, stress concentration in the cement lute. And eventually we get repetitive strain injury in the cement fractures and breaks down. Okay, now, one of the ways we can get around that is changing design. As I've mentioned, an anterior bridge ideally should be a cantilever. And what happens now? Exactly the same thing. Our lower tooth goes up and down and it goes bang onto the upper tooth, from metal onto the upper tooth. But now we've got mobility, and what happens? The tooth does this. It moves in its periodontal ligament. The stress is dissipated by the movement. Okay, huge principle. So if we want a if we want an adhesive bridge to work anteriorly, then choose the design of a single cantilever. Now, if we had some mobility here, a little bit of mobility, and you decided I'm going to go and do a fixed bridge, then depending on the mobility, when you went forwards and backwards here and here, the bridge may still have that mobility from excessive mobility that's been reduced, but still enough to take the stress off the cement lute. If it didn't, what else can we do to try to protect the cement lute? We can do tooth preparation. We'll talk about that in a second. And we can also take the metal right up to the incisal ledge. So in fact, the patient, when he's grinding forwards and backwards, can never get the lower tooth to actually hit the upper enamel because it's completely covered by metal. So there's no tensile stress then in the cement. So in terms of longevity, we have our studies. Now let's look at tooth conservation. The original concept that the Maryland bridge was a completely non-preparation bridge, it's got to be reconsidered, and it's got to be reconsidered because of increased risk of failure. So most people would now suggest that proximal extensions, 3/4 crown, labial grooves, labial wraps, these are more important in terms of longevity. And unfortunately, when you increase longevity, the downside is most usually that you have to do more tooth preparation and therefore lose conservative approach. However, let's put this into context now. All of these little bits of preparation that we're doing are there only in enamel. We're not doing tooth preparation deep into dentin, so it's not like a full crown preparation. So if this happened to fail, the bridge happened to fail and it came off, then yes, there would be some grooves, receipts in enamel, but there'd be nothing in dentin. So in theory, your patient could just carry on regardless. And again, we know from the studies that if we do more tooth preparation, then we will have better performance. So we'll get better success rates with tooth preparation than without. So what are these tooth preparation features that we can use? And I will draw your attention more to the lower, where we usually do more preparation more often than the upper, because the lower is in tensile stress. So let us just imagine now that we're going to do a lower, let's look at a worst case scenario. We're going to do a lower canine to canine bridge. Okay, 4 lower incisors lost, canines pristine, no problems with them whatsoever. We've decided we're going to do a Maryland bridge. So in designing your tooth preparation features, we have to now think about resistance form, retention form. In terms of resistance form, when we bite on the pontics, the bridge will be pushed downwards. Therefore, resistance form, I need to have some form of ledge, shelf, resting, call it what you will. And in fact, here I have 1, I have 2, I have 3. This is not what we'll do for every case. This is the maximum, okay? This is the maximum resistance retention form we would ever dream of putting into a case. So in order to stop apical displacement, we have a resin. How else can it now displace? Okay, think about that lower 3 to 3. Well, we can go into a protrusive movement, and that means we could be bruxing at nighttime. Okay, as we're bruxing at nighttime, the pontics are being forced lingually. Therefore, I need something to stop the lingual displacement. And what do I have? I have a groove, a mesial groove and a distal groove. And a mesial and distal groove, when the metal goes into those grooves, that now means it cannot displace lingually. Okay, remember these grooves will have a buccal surface and a lingual surface to them. The bridge will be seated from the incisal, not from the lingual, from the incisal. The grooves will go down, the metal will go down into the grooves. It cannot now physically displace lingually. This is what we're talking about with resistance form. Final thing now, final movement is the chewy toffee, where the bridge can come out incisally. And for that, we're talking about very much now, not resistance form, but retention. And retention is a feature of surface area. So this is now about as maximum wraparound as you can get. And we're talking here about guide planes. So these are all the different types of preparation that you can do. And we'll put that, as we said, more into a lower, a little bit less into an upper. And here's a little situation now where a patient, an elderly patient, has lost a lower central incisor. We're not wanting to do something too difficult for her. So we've done a little bit of tooth preparation and we've replaced the lower tooth with a simple cantilevered Maryland wing. If we look at our tooth preparation on our silver dies, we've got rest seats. We've got 1, 2 rest seats. I've got a mesial groove, I've got a distal groove. You can see them now on the metal. Rest seat 1, rest seat 2, mesial groove, distal groove. That means that it goes in and fits like this, click. So it's a very, very good fit. And all I'm doing is I'm taking stress away from the cement flute. Also, what we know is, again, from the cantilever situation, that if we have a lot less abutments, then we'll have success rate which increases. This is all across the board when it comes to bridge design. And therefore, we do see cases where we have multiple abutments. You've seen one earlier. Multiple abutments will lead to failure. Therefore, when we see multiple abutments like this, it is better long term to go change that for a single cantilever. Why? Well, we have here 3 chances of caries. So if any of these fail, this one fails, it may not fall off because it's still on those 2 teeth and we can get caries. Likewise, that can happen. Likewise, that can happen. So we have 3 chances of caries. If we go and replace this bridge, as we're going to, with a single cantilever off the lateral incisor, with rest seat, we've used a little pinhole channel here, distal groove and mesial groove, distal groove and mesial groove, and then cemented in one place. We have only 1 chance of failure. It's not going to lead to any caries. It will drop off. And as long as we have the occlusion correct as well, remember the occlusion says no guidance on a pontic, then we have the periodontal ligament to protect us. Well, let's talk about aesthetics. One of the problems with anterior bridge work, which is adhesive, is of course that we have metal show through. And in the case I've just shown you earlier here, I've deliberately kept the Maryland a long way away from the incisal edge to try to make sure that my incisal edge does not go too grey. So that's our major problem with aesthetics. How can we overcome that? We can overcome that by moving to zirconia adhesive bridge work, and this is comparatively new. We don't have the long-term studies. We're getting up to 10-year studies now with zirconia. But if we look at the all ceramic resin bonded bridge work, estimated failure rates of around about 11%, and for metal framed resin bonded bridges, 4 to 5%. So we're looking at twice the failure rate at the moment. Why is that? Well, that is because it's new technology. That is because zirconia is not as strong as metal. That is because we are not using the correct shapes and forms for our connectors as yet. A follow-up of 15, again, a different study by Saylor, 2014, done particularly well over 8 years, showed 100% success rate. But that is one individual working correctly. What we're wanting to do is see multiple studies. And a meta-analysis showed an estimated 5-year success rate, 88% for metal-based bridges, 84% for non-metal-based bridges. Again, more or less getting down that line of twice the failure rate. And finally, our estimated 5-year success rate for zirconia, 92%, but that is estimated. That is not retrospective. This is prospective and estimated. So do we do them? Yes, we do. Do we do them in every situation? No. We do them again when we have a cantilever, when we have the periodontal ligament as a stress breaker. We do them when we have the ability to have a long connector. And we also do them when aesthetics is most important for our patient. So we have a young lady here at the moment who's wearing 2 typical resin bonded bridges on her canines. In fact, not only are the canines showing very gray, but we can see the metal showing through on the canine wing in any case. And our patient's unhappy with this. So we remove the resin bonded bridges. And the next problem we see from an aesthetic point of view is that our pontic sites are not ideal. So aesthetically, we have to go and improve those pontic sites. And those pontic sites are now improved with a little bit of gingival rotary curettage to drill into the soft tissue to create an ovate pontic site. And this is what we do here, creating an ovate pontic site. This is after a little bit of healing. And again, we've used the resin bonded metal bridges as our prototype, as our temporary. We can get them on and off. We've simply added a little bit more onto the pontic to let it sink in. We take our final impressions and we make now 2 zirconia single units, single cantilever units. And these are now placed in. Aesthetics much better. We have the natural translucency of the incisal tips as opposed to the dark metal. So yes, aesthetics can be good. However, longevity still is in question. And I would not say at any stage that the longevity is as good as metal-based at this present time. So let's now move on to our conventional bridge, and we'll go through exactly the same things with our conventional bridge. First of all, longevity. So we'll go back to that Peterson study, and our 5-year survival rates for conventional bridge were just over 90%, a little bit better than the 88% that we had for resin bonded bridges. But again, this is a 5-year survival rate. What else do we know about them? That if we look at a meta-analysis of all the bridge design studies, bridge longevity studies that are out there, then again, we've got something roughly 75% at 15 years. And that, I think, is a very, very good survival rate. 3/4 of the bridges that are done in this particular study worldwide that have been reported on are still there at 15 years. I think that's a good survival. Especially if you then start to understand bridge design fully, you'll get better success rates. So these are bridges that have been done worldwide in studies where possibly the clinicians doing them did not fully understand bridge design, the ins and outs. And if you can learn bridge design much, much more thoroughly, have a better understanding, then you'll get better success rates. And remember, bridge design is not taught very well at dental school. You have to pick bridge design up at postgraduate education, and there are not that many courses on bridge design. Dentists themselves, funnily enough, estimate that their fixed partial dentures, their bridges, will last about 13 years, okay? Which again is not bad. It's in that same realms of 15 years. Priest, again in 96, that same paper, looked at single tooth replacement bridges, and again, the best and the worst failure rates. Best failure or worst failure rates were 20% over 3 years. So only an 80% success rate over 3 years versus 97% success rate over 23 years. And again, we would like to be in that realm of a 97% success rate over a 20-year period. And that is absolutely attainable if you understand bridge design, but only if you understand it thoroughly. Let's look at tooth conservation. Now, obviously, we're cutting down a tooth as opposed to the adhesive bridge. So the teeth are going to be much less conservative in terms of the preparation. And we have various studies out there which look and show us the amount of tooth preparation and what the problems are with that. And the one that's pushed out there all the time, Bergenholtz, shows us that approximately 15% of all abutment teeth will require endodontics compared to 3% of crowns. So we have a much greater increased risk of abutment teeth going non-vital. We have to ask ourselves why. Is that because they take greater loading? Possibly. Is that because of poor bridge design? Is that because when a lot of dentists are doing their bridge design, they're doing fixed bridge work as opposed to either single cantilever or fixed movable? Remember, with a single cantilever, we don't have to go and make teeth so that they're parallel to each other as you would do with a fixed bridge. So a single cantilever is a much more conservative preparation. It's a crown. What about fixed movable? Fixed movables, again, are more conservative than fixed because we don't have to parallel teeth up. If I've got two teeth where the long axes are like this, and I now want to do a fixed bridge, I've got to do something to that posterior tooth. So I've got to over prepare maybe the mesial aspect. The more I prepare, the greater the chance of injuring the tooth. However, if I'm doing a fixed movable design, I'm preparing down its long axis, and then I'm having a fixed movable stress breaking attachment which is fitted at the same angle as the distal abutment. So it's much more conservative in tooth preparation. So again, at the front of the mouth, our alternatives, we can't do fixed movables at the front. The front of the mouth, our alternatives are the single cantilever, where we're cutting down just one tooth, or fixed bridge work. So with a 2-unit cantilever, longevity studies would suggest that they last on approximately 15 years. And most of you, I'm sure, have done cantilever bridge work. And cantilever bridge work, which involves preparation here of one canine to replace a lateral incisor. Other alternatives, other examples of this: central incisor being replaced by prepping the other central incisor. So a cantilever of the central incisor, this central incisor worn down, aesthetically poor, labially placed, a lot of wear on the labial surface, patient very keen to have that crowned in any case, and therefore rather than crowning and putting an implant in, a single cantilever did the job much more aesthetically and without any of that trauma. And here's our single cantilever. Funny enough, single cantilevers, when we design them, are the only bridge design now where we still use Antes law. You may remember Antes law, 1926. Antes law was first written, and it's been passed down over the years. But nowadays, in terms of more modern designs and scientific studies, we only ever use Antes law in that one scenario, and that is for the cantilever bridge. Now, what do we see here? We see a single cantilever, but now we see a central off the lateral, and that is breaking Antes law. So we have done it. The patient is fully aware that we've done it, and we've done it for a reason, because the other central incisor was not prepared. This was already an existing crown. They lost their existing post crown, and so we decided in this instance to give it a go. The patient is well aware that this is experimental, but the patient has taken it upon themselves to say, I accept responsibility. If it fails, then maybe we have to do something else to try to minimize that chance of failure. So important with all bridges for their success rates that you get the occlusion right. Another problem area that we have in dentistry is that you are not taught enough about occlusion as an undergraduate. That is fact. And therefore you have to learn on postgraduate courses about occlusion. And we have 5 principles of occlusion. RCP equals ICP around R18. Mutually protected occlusion. Anterior guidance. No non-working side interferences, and making sure we have posterior stability. The more you adhere to those 5 principles of occlusion, the better your success rate will be. The more predictable your success rates will be. In this situation, what can we see? We have guidance. So guidance is really important here. And we must not have guidance on the pontic. If we have guidance on the pontic, that's going to put rotational stress on the tooth, and potentially the cement loop may break, the porcelain may fracture, the tooth may fracture at gum level, or quite possibly, if we have protrusive guidance on that tooth, it will rotate just like a tooth that's got orthodontic movement on it. And then you have a gap between both centrals, which is very, very poor aesthetically. So we need to make sure that we have guidance on the contralateral teeth, guidance on the abutment, guidance on the central incisor next to it, guidance on the lateral incisor, but only on the pontic, a light intercuspal holding contact. Now moving on to fixed bridge work at the front of the mouth. Remember, we're talking about the missing anterior tooth, not teeth. So when do we go for fixed bridge work as opposed to cantilever? We go to fixed bridge work when we have mobility. So our mean lifespan for 3 and 4 unit bridges, 9.6 years. Now remember, that's come down from our average life expectancy for a 2-unit cantilever of 15 years. Another study, mean lifespan for 3, 4, and 5 unit bridges, 12 years. Very, very difficult. And this is one of the problems we have in the literature, is that it's very difficult to do studies on bridge design where they are all replacing the same teeth. So we have most of our bridge design studies lump lots of different bridges together. So it's very difficult to find the success rate of a cantilever replacing a lateral incisor from a canine, because there's not enough done at any one time to put that into a study. So all we can do is extrapolate and try to get a feel from the literature about what is best for our patients. So in this situation, okay, for fixed bridge work, what's the advantages and disadvantages? First of all, we do them when we have mobility. And here's a case where we already have a 3-unit bridge, central and lateral incisor, but this is a perio patient and we have mobility of the bridge. I can get the bridge and I can move it forwards and backwards. It's been repaired several times. It's come to the end of its lifespan, but now we're going to increase the number of abutments because of that mobility and use 3 abutments. Remember what we said earlier on bridge design, that if you increase the number of abutments, you have an increased risk of failure. So we do have that increased risk of failure. However, if I don't use that 3rd abutment, I'm going to have mobility. That mobility will get worse and worse and will probably lead to a failure in any case. So it's important that you understand the failures, why they occur, so you can try to limit them. So in this instance, we're using 3 teeth. 2 teeth already been prepared, but I'm having to use the 3rd abutment tooth. In a case like this, all the teeth have been crowned. So realistically, I'm not hurting the teeth anymore. I'm still conservative in nature. So what we're talking about more is if you're cutting down 2 or 3 healthy teeth for a fixed bridge, that's 2 to 3 times less conservative than doing a single cantilever. The other aspect of aesthetics that we should talk about, and especially in relationship to implant work, is if we are missing ridge and soft tissue. So in a case like this, where the pontic is, we've got a deficient pontic site, both in terms of vertical nature and horizontal nature. And in fact, the major concern for this patient is that they are spitting through the bridge work, that they are spitting and feel as though their voice and their phonetics is poor. So what we aim to do here is to go and increase the size of the pontic site, pontic area, make it into a concave pontic area, an ovate pontic, so we can have a bigger bridge. We can also have a better aesthetic bridge where the pontic will go into the tissue, as opposed to here, the pontic is sitting on the tissue, and also block off those spaces. So here is our definitive work. We've done our connective tissue graft, as you can see. We've taken a chunk of connective tissue from the palate and we've sutured it in place into this area. You can see the amount of bone volume that we've now added, and we're now working with the technician to create an ovate pontic site. Our technician, in this instance, I haven't used a burr as I did with the adhesive, the zirconia adhesive bridge case earlier. This case, we've used a dental technician and he has cast scored the model so that when we fit the bridge in place, we've got the pontic pushing into the soft tissue. As the pontic pushes into the soft tissue, the water gets displaced. So here's our beautiful now 4-unit bridge, lovely ovate pontic, and a much better predictable aesthetic result. We have gum loss and bone loss with a single tooth implant. Much more difficult to get a predictable, good looking result. Much easier to get a predictable, good looking result with a bridge, conventional bridge, than with a single tooth implant, if we're just looking to build up the ridge and the soft tissue profile. Aesthetics, from an aesthetic point of view, again, very much depends on the quality of your technician. And I would suggest to you that you need to sit down with your technician. You need to go on courses with your technician and you need to go and choose a good technician or learn with the technician. Many good technicians around out there. If you're interested in the ones that I use Gary Jenkinson from ART Lab in Sheffield, Phil Reddington from Beaver Dental in Yorkshire. I use Simon Newbold in London. I use Marco Bacisa in Cornwall. Those are great technicians, okay? And those are technicians I would suggest you get in touch with if you want to improve the aesthetic work of not only your bridge work, but also your veneers and stuff like that. Get in touch with one of those people and then start a conversation and start working with them. That will improve your standards as well. So we're going to move on to our final discussion, and that is replacement of the anterior tooth with an implant. So remember that first of all, the implant in terms of aesthetics is the least predictable aesthetic result, but we'll come to that. Let's look at longevity, and again, longevity studies. We have the St. Peterson studies here now. We've been looking at not only single tooth implants, but conventional and adhesive bridge work. 5-year survival rates for implant retained single crowns, 95%. So we've got adhesive bridge work at 88. Only a 5-year study, mind. We've got conventional cantilevers at 90%. We've got single tooth implants at 95%. But this is only a 5-year study. What happens to all our restorations in the mouth? They age, they corrode, they're in a hostile environment, they will fail. So 5 years is not ideal, long-term study. I'd like to see much longer studies. One of the problems we have with longer studies with implants, however, is this problem of peri-implantitis or perimucositis. This is something that's getting more and more prevalent and is affecting more and more implants. So in the olden days, when we used to just use the Brånemark, original Brånemark criteria and success rates, then we were looking at a 90% success rate over 15 years for most of our implants. Now I don't think we can say that. Now most implantologists, most surgeons, when asked how long do you feel that your implant or my implant will last, will say probably about 15 years. That puts it directly in competition with the bridge. So at the moment, from my point of view, in terms of longevity, bridge work and implants probably in that same region, conventional bridge work. Adhesive bridge work, probably just a little bit less. What else do we know? We know from Freeburg that failure rates 10% over 3 years. We know that failure rates for single tooth range dramatically, 9% over 3 years, 0% over 6 years. Okay, so again, we will see an awful lot of operator variability, and therefore it means if you want to do this work, you have to get good at it. Do not think you can potter, do a little bit of bridge work, do a little bit of adhesive bridge work, do a bit of this and a bit of that. If you want to get good at something, you therefore need to start restricting yourself. The people who do the best implants with the best longevity are those that only do implants. The people that get the best longevity for bridges do multiple bridge work. Again, implants into the mandible have a higher success rate than those in the maxilla. Shorter implants fail at a faster rate than longer implants. Smokers have more problems with success rates than non-smokers. So again, as we're building up this picture of whether we should go with adhesive bridge work, conventional bridge work, or implant work, we have to start looking at many variables. And those variables can be not only aesthetics, but how much is the bone volume there? Is it going to be a long implant versus a short implant? What about the patient's habits? Do they smoke, yes or no? A smoker will not have a huge detrimental effect on your bridge design. It may be from a periodontal point of view, but not from a caries, from a marginal seal point of view, from an endodontic point of view. However, the smoker will have twice the failure rate from an implant. So we have to look at where those implants are going to be placed. Maxilla versus mandible, smoker versus non-smoker, long implant versus short implant. There are many, many more variables than this. This is not a webinar on how to do implants. This is a webinar comparing success rates with implants versus adhesive bridge work versus conventional bridge work. Tooth conservation goes without saying that we are not going to be prepping a tooth with a minor amount of preparation or a major amount of preparation as adhesive or conventional bridge work. However, when we talk about conservation, it's not just tooth conservation. If we have a failed implant, that often leads to large amounts of bone loss, large amounts of soft tissue loss. And if we do the implant and it fails, very often our patient then may need major bone grafting, major soft tissue grafting. If our bridge fails, we have the chance very often to go back and either do a new bridge or then to move to a single tooth implant. So my treatment planning options nowadays have changed dramatically because of the rise of peri-implantitis, which has reduced my long-term success rates with implants, my predicted long-term success rates. So many years ago, if I was looking and seeing a situation where the tooth may not last a long time, I was very much into the thought process of take the tooth out, get an implant in there, maintain bone, because we thought implants were going to last at least 30 years. Now I've had a change, and that change is the tooth is in there, it is not ideal. Can I work with that tooth? Can I get some lifespan out of that tooth? Maybe I can delay putting an implant in for 5, 10, 15, even 20 years. If I can do that, then I think my patient will be better off. And we hopefully will be in a situation in 5, 10, 15, 20 years where we've cracked the problem of peri-implantitis. Finally, aesthetics of implants. And we mentioned this a little bit earlier on with the aesthetics of implants and how unpredictable they can be, as opposed to the predictability in that first study we looked at by Priest, the predictability of the partial denture. So why are single tooth implants, especially at the front of the mouth where we need the aesthetics, why are they potentially unpredictable? And again, we just hark back to the Priest study. The least predictable aesthetic replacement is the single tooth implant. So let us look and finish this brief webinar with aesthetic assessment. And what I'm going to be doing here is going through 3 of the major aesthetic assessments that you need to be looking at prior to deciding whether you're going to go with adhesive bridge work, conventional bridge work, implant, or even the partial denture. And this will be relevant to all the different types of restoration. The first thing is, of course, lip line. And we can have 2 types of lip line. We can have the low lip line, the high lip line. Well, let's deal with both of those. First of all, the low lip line. The low lip line is an easy case for a single tooth implant, for an adhesive bridge, for conventional bridge. And why? Well, it's the obvious fact that we cannot see the join between the restoration and the gum. And we're always worried about this problem called recession. And if we do a bridge and we've got a porcelain fused to metal bridge or even a zirconia bridge and we have recession, then we can get black triangles in between where the incidental papillae used to be, and we can get margins on view. If we have low lip lines, then even if we do have that, that does not become an aesthetic problem to us. So even if we do an implant, and remember the implant is the least predictable aesthetic result. Why? Not because of the porcelain, but because of the potential for recession and losing soft tissue around it. So if we have a low lip line, the implant now comes very much into play. And we have a case here where we have a patient who has got internal resorption occurring on the upper right central incisor. We're going to be losing this tooth. She also at the same time doesn't have a particularly aesthetic anterior smile line. Canines very dominant, lateral incisors very short, big diastema, and of course this darkened tooth, which you can see now on the right hand screen. We go through our normal planning, which involves thorough examination, mounted study casts. On the mounted study cast, we do our diagnostic wax up. We have our prototypes made for us. We do cosmetic imaging, and we also do, obviously, all our periapical radiographs, CT scan, etc. That's our package of our treatment planning, and we can't do a thorough job unless we do all of that. So here's our diagnostic wax up, and during this process, we're going to be losing this anterior tooth. We're going to be closing off the diastema, which means therefore that I need to be doing veneers or crowns, veneers on these teeth so that I can just move out the mesial aspects of them and create a much better golden proportion between the centrals, laterals and canines. And hence this is my wax up, making the teeth longer again so that we've got a much flatter anterior occlusal plane. These are my prototypes. We go into the mouth. We're doing slice preparations on the anterior teeth, and we've put our implant in. First thing you look at, you see that the implant, we've taken a tooth out and we've got recession. Now, we'll talk towards the end of this webinar about how we minimize that. But naturally, when you take a tooth out, you will get recession. If you're going to take a tooth out and it is a high lip line, then that recession will show, even if it's a perfectly good tooth. And the reason that we get recession is because that very, very thin amount of bone, okay, so the thin amount of bone you've got just here and interproximally, that thin amount of bone, that bone peak there, gets its innervation, its blood supply from the periodontal ligament. Take the tooth out, we take the periodontal ligament away, and therefore we lose that very, very thin spike of bone on the labial aspect. And that bone then rounds, it resorbs away by about 0.5 to 1 millimeter. Hence we get the soft tissue and bone loss, which now means that I've got about 0.5 to 1 millimeter of recession. Does that make a difference in this case with a low lip line? No. As long as your patient realizes when they do this and lift up the upper lip, they will see uneven gingival margins. This patient wasn't the slightest bit bothered about it. So we do our tooth preparation, supragingival margins. We're doing our impression for the single tooth implant. We put our prototypes on and you can see our problem here. Also, that problem may have been caused by the surgery. If we'd have placed that implant a little bit further palatally, if we'd have changed the emergence angle of the implant, then potentially we've got a little bit more coverage just here. Anyway, as I mentioned, in this case with the low lip line, it doesn't matter as much. Our prototype's in place. We're now going through the cementation protocol, and we have our finished result where the teeth are longer. We've got a nicer aesthetic occlusal plane, but we've lost that 1 millimeter or so of soft tissue. And of course, we've also lost peak of bone on the distal aspect. Let's look now at the other alternative, which is the high lip line, and how we're going to overcome this. And again, our final case, you can see when she smiles, we don't see any problem whatsoever, and we've got a satisfied patient. So the high lip line, we need to approach in a slightly different way. I've already mentioned to you that the implant placement may be different, and we may have to work a little bit harder to try to get the aesthetic result. And in these cases, you may decide with a high lip line that it is better, more predictable to go for bridge work. So we have a case here where, again, this is our lip line, and we can see now the gingival margin already. The patient has got a single cantilever in place. And you may decide that, okay, I'm going to just go and replace the single cantilever. However, in this situation, our patient was unhappy with the bridge and wanted an implant, came to us with an implant. So we have difficult aesthetic criteria to fulfill for the patient's success. We also have, again, canines which are a little bit longer, lateral incisors which are shorter. Overall width to length ratio of the central incisors are poor, and therefore we're going to have to change that. In this instance, we're going to use an implant, and we're going to put a veneer on the lateral, to lengthen them, also take a little bit more on the mesial aspect, and then we're going to do, again, single ceramic crown on the upper left and implant on the upper right. There's our situation to start off with. Same planning criteria that we go through beforehand. That's photographs, periapicals, CT scan, mounted study casts, diagnostic wax-up prototypes. And here's our preparation. We also have a tooth preparation guide, which is going to help us in terms of the amount of tooth preparation and where we're going to do the preparation. So we minimize the amount of tooth preparation that we're going to do. And we're at the stage where the implant has now been placed and we've got our prototypes on. And we're working with our prototypes, and it's important that we spend more time with our prototypes. And what we're trying to do now is get the right soft tissue. So our implant has been placed at a deeper level so we can create a better emergence profile, and the implant has been placed further palatally so we've got more thickness, more bulk of tissue on the labial aspect. And our patient is now wearing a temporary crown on the implant and abutment, temporary crown on the tooth, and we've just done some temporary composites on the two lateral incisors. Now we're going to take our impression. So our prototype's been on for a long period of time. We've got the right soft tissue protocol. We've been working with the soft tissue to change the emergence profile. Okay, remember, steeper emergent profile, soft tissue around tooth, around implant goes up. Flatter emergent profile, okay, the tissue level around teeth, restorations, implants will come down. So I'm now playing around with the shape of my emergence profile of the abutment and the prototype. And once we've got it right, we have to copy. And we copy in two ways. Copy number one is we make a customized impression coping. You know from having done implants that the impression coping is round. I've now created a more triangular hexagonal shape of my soft tissue profile. If I now put a round impression coping in, all that will happen is the soft tissue will now slowly come round and envelop that round impression coping. When that goes to the technician, he casts a model, he'll have a totally different idea of what the soft tissue looks like now on the model than in the mouth, because the soft tissue's changed. So one of the ways in which we can try to get a soft tissue good profile, exactly how it is to customize the impression coping. And we do that very much by taking a standard impression coping, sandblasting it, putting it into place, and then syringing a light cured composite underneath between the gum and the coping. So the gap before the soft tissue's gone and close that gap down, we syringe in a light cured flowable composite, cure it, and now we've stabilized the soft tissue. Look at that soft tissue profile compared to where it is here. And you can see we've got exactly the same soft tissue profile. The other way in which we do this is we now take an impression of the prototype. But rather than taking a conventional impression, as you would do in a tray, we take the prototype out, okay? Take it out in your fingers, Okay, in a Dappens dish, mix up some impression material, put it in the Dappens dish, and then we take an impression of the gingival margin in the silicone. So not an impression, labial surface and incisal edge, impression of the gingival margin. Our technician can then duplicate that in a resin. He can scan it and he can get the exact emergence profile that has now created that soft tissue. So that's how we create the same profile of the final restoration from our temporary crown. And here you can see the implant placed further backwards and also a lot higher. You can see I'm using silver dyes for my restorations. And now into the mouth, look at that lovely soft tissue profile. And that's only come from wearing the prototype for about 3 to 4 months, working with it, changing the emergence profile. So I've got the margin exactly where I want it to be. A lot of work, much more costly than just a single implant and crown. You're seeing the patient time and time again, maybe 3 or 4 times, to take the prototype off, to amend it until we get a stable gingival margin. Then we have to copy. My zirconia abutment, and we're now ready to cement the crowns on and the 2 veneers. All zirconia, gone very white. This gentleman's a male model, and we've got a nice end result taken him from his initial fairly unaesthetic bridge work to his new definitive veneer, crown and implant work. A lot more work. Next thing we have to think about is biotype. And important again for implant, where you're going to have much more chance of soft tissue recession. Okay, certain biotypes recede more, certain biotypes don't recede as much. And therefore, if you want a better aesthetic result from your implants, then choose the thick biotypes, not the thin biotypes. So let's look at both, and let's look at the thin biotype first of all. Our classic thin biotype is the tooth that is triangular in shape. Straight away, I've got a triangular shaped tooth. Okay, the thin biotype classically has a long distance between zenith and tip of interdental papilla. The thin biotype has got very thin tissue, which you can look at and almost see through. Very, very thin tissue. The thin biotype may have some cementum on show. So here we have a thin biotype. We have problems with bone loss around this particular tooth. You can see actually it has a Maryland adhesive splint in place, but it's become debonded and moved away. And now he's got a diastema, which he never had before. This tooth has migrated out, and he wants this fixed. And he wants to go for an implant. We've decided to go for an implant because the teeth either side are good, healthy looking teeth, and we doesn't want a bridge of any type. So what's our problem? Our problem, first of all, is the triangular tooth and the fact that when we come to do our surgery, we'll get more chance of recession. Now, what does a triangular tooth mean? A triangular tooth means that if I put an implant in here, we'll get a bit of bone recession labially. Okay, we can cope with that sometimes by placing the implant deeper, more palatally, and changing the subemergence profile. The other area where we're going to get bone loss is the interdental papillae. With a triangular tooth, that matters because with a triangular tooth, what will happen with recession is I'm going to get a black triangle. So put 2 triangles together and you have a big black triangle in the middle. If you put 2 rectangles together, you'll have no black triangle. So rectangular teeth, far easier aesthetically to control when you're doing restorations on single tooth implants than triangular shaped teeth. We've got a triangular shaped tooth we're going to have to deal with. Okay, and straight away you can see there's my triangle, there's my triangle. This is just the O tooth, which has just been bonded back into position to act as a temporary restoration. We put the implant, as you can see, more palatally placed, more higher up. And we now start to work on, again, our temporary. At the front of the mouth, always important that you put a temporary restoration in place. And here's our temporary restoration, okay? And at the moment, you can see a couple of things happening here. You can see that we've got a rectangular tooth next to a triangular tooth. And when we look at aesthetics at the front of the mouth, the first thing you're always taught about with aesthetics is the teeth must look exactly the same. Your two central incisors have to look the same aesthetically. So don't go and put a triangular tooth and a rectangular tooth next to each other, because that will show immediately. So I have a problem here. I either go for a triangular tooth to make both teeth look the same and lose an interdental papillae, and have a black triangle, or I go and have a rectangular tooth, recreate or eliminate the black triangle, but have two teeth that look very, very dissimilar. Or third option, and we'll deal with this option a little bit later, is the use of some pink porcelain. So that's my predicament. We're doing a customized, so my patient's been wearing that temporary restoration for a while, and the soft tissue zeniths, exactly the same. We've done a good job there. But as I mentioned, we've got this problem to overcome of triangular tooth next to rectangle, or missing interdental papillae. Okay? In a way, our patient has to choose one or the other, or maybe we can try and combine it. So again, customized impression coping, exactly as before. And here's a nice view of what it looks like on the model. And theirs would be your normal impression coping. And here's the excess global composite, and we're taking our shades, and we're using a titanium abutment and an all ceramic restoration. We're placing the titanium abutment. We've still got a very, very nice tissue profile there, and now we're putting in our final definitive crown. And the way in which we're trying to overcome this triangle versus missing interdental papillae is we're trying to make our mesial marginal ridge match up with the mesial marginal ridge of the contralateral tooth. Okay, so this is all about creating an image. We do have a triangular tooth next to a rectangular tooth. How can I make my rectangular tooth look more triangular? Okay, that's what I'm trying to do here. So I'm highlighting the mesial marginal ridge as being triangular in shape. I'm putting more depth of color into proximally. So in terms of the whiteness, you see a white line here matching up with the white line there. You see the highlight there matching up with the highlight there. You see a little bit of dark staining, a lot more dark staining. And by doing that, we try to give the illusion of a triangular tooth. Does it work? Yes, it works very well. Again, fortunately, he's got a low lip line. Well, this is one of the problems we're going to have with biotypes. Much better to go and work on a thick biotype, as in this scenario. So here we are, another case, not exactly a single tooth, but this is now a 3-unit bridge on 2 implants. Okay, the patient's wearing a partial denture. Same criteria again: mounted study casts, diagnostic waxing, prototypes, preparation guide, CT scan, photographs, cosmetic imaging, everything exactly the same. Here is the implants. Now look at that soft tissue. That soft tissue is thick, it's fibrous in nature. You insult it, nothing happens. So this is now an ideal case for anybody, for the beginner, to go and do implant work and still have very, very forgiving tissue. Okay, so this is now pushing itself towards implants rather than anything else. It could be a scenario where, if that tooth is extracted, a 6-unit canine to canine bridge would be a reasonably good alternative. But because of the fibrous nature of the tissue, we put our abutments in place. Our tissue does not recede, it does the opposite thing. it comes down and grows around the bridge. And here you can see all the soft tissue coming down and enveloping that bridge. And so we get a very, very nice, long-lasting aesthetic result from there to there. Third part, which again is going to influence, and this is the final part now of this particular presentation, is we're looking at bone volume. And bone volume will mean if you have enough of it, you can do an implant. If you don't have enough of it, in order to do an implant, you have to do a bone graft and a soft tissue graft accompanying it. And you then say to yourself, is that worth it aesthetically? Can I control the aesthetics of multiple surgeries versus should I be doing adhesive bridge or conventional bridge? Every single case you do will be different, but you have to weigh up all of these options. Now, one of the best ways to ensure that you've got adequate bone volume is to try to take the tooth out before you get bone loss. Okay, the problems we have with loss of bone volume occur in two situations. The first situation, the tooth's been missing for a long period of time, and we don't have enough vertical or horizontal bone. Second situation, we find ourselves with the tooth in place, but we have a large area of infection. We have to take the tooth out, let the area of infection resolve. Often the buccal plate has been lost, and then we're left with a concavity, and again, loss of vertical and horizontal bone. So if the tooth is going to come out, if it has to come out, get it out early and get a predictable end result by doing a immediate placement. Immediate placement and temporization, not immediate loading. So I'll give you an, for instance here. We have a tooth which is root filled. You can see a post crown in it. We have a fracture down the long axis of the root. And at the moment, that has not caused any pocketing, any loss of labial plate. So we're still in a relatively healthy situation, although the tooth has to come out. We have a root fracture. So what are we going to do about it? Remember, if I take this tooth out and my patient has a high lip line, I'm going to get 0.5 to 1 millimeter of recession because that gum margin there is held in place by the peak of bone here, which is itself getting its blood supply from the periodontal ligament. Take tooth out, lose periodontal ligament, lose blood supply, recession. And that's usually 0.5 to 1 millimeter. So think, how can I get around that? One of the ways we've got to getting around that is to do some orthodontics first of all. So this is what we're going to be doing. So we're going to do some rapid extrusion. So I've taken the old crown off, had to cut it off. I put a new temporary one on. And now with that temporary in place, I'm doing some orthodontics. All I'm looking to do is to get rapid extrusion 1 millimeter in 1 month. So in terms of talking your patient into having orthodontics done, you're only realistically asking him to wear the orthodontics for 1 month, and that will bring that soft tissue down. So let's just look at the soft tissue levels. We started off the same. With my prototype on, we're still the same. Now we've brought it down by about 1 millimeter. Okay, that's all we need. And what we've got now is 1 millimeter of extra soft tissue, 1 millimeter of extra bone. When I take the tooth out, I lose the 0.5 to 1 millimeter of bone, which means my gingival margins will then end up in the same position. So once the 1 month orthodontics has been completed, we're now going to go and take that tooth out, and we're going to do an immediate replacement. So we're going to prepare our site, place the implant, and then put a prototype in place. So this is what we've now done. The implant is in place. Soft tissue is looking a little bit soggy. Yes, we've taken the tooth out. And we're now going to go and put a temporary abutment and temporary crown on. So here's my temporary abutment and temporary crown. And we now wait for that normal, traditional 4 to 6 months for the maxillary implant to go and integrate. During that time, we have our prototype crown on. Important with the prototype crown that it does not contact the opposing tooth. So we always make sure that that opposing tooth or the palatal aspect is scooped out. So in intercuspal contact and in protrusive contact, there's no contacts on that prototype whatsoever. Now, as you well know, during a 6-month period, if we do that to a natural tooth, the lower tooth will over-erupt. So we also have to split the lower tooth to the other 2 teeth next door with a little bit of acid etch and composite to stop the over-eruption from occurring. Okay, now we're at the 6 months time. We're taking the prototype and the temporary abutment out. We're taking our definitive impressions for this is an IMZ implant. Taking our definitive impression, making our custom-made abutment, and sandblasting the custom-made abutment and then cementing our crown on. And you can see the same level has now been maintained. So we've now got a single tooth implant, triangular shape, but we've maintained the triangular shape because we've got no bone loss. We've got no bone loss because we've got at least 1 millimeter of extra bone by doing the orthodontics in the first place. Hence, we've got a very, very nice interdental papilla and still have 2 triangular teeth. So that is my ideal way in which I can do it. Unfortunately, it doesn't happen very often that we manage to get the ideal scenario. So let's look at the non-ideal scenarios where we have thin bone and thick bones. Okay, so the first case is I have some thick bone and we can do a traditional single tooth implant. So we look, this patient's got a 3-unit bridge, but for whatever reason, we've not had any bone loss on the ridge, and the patient wants to have the bridge replaced with an implant. Also doesn't like the aesthetics. So traditional implant placement, we've got large amounts of bone, we've got a nice thick fibrous tissue as opposed to a thin tissue. We've removed the bridge, we've removed the old crown, we've placed an implant with a zirconia abutment. Again, to make sure that we've got good aesthetics, the implant has been placed more palatally, a little bit deeper than normal, so I can get good emergence. If I've got good emergence, then my prototypes, I can copy them. Here's my definitive crowns. And here we are now fitted in the mouth, individual crowns instead of a bridge, gum margin exactly where we want it to be. A really, really nice, aesthetic, predictable case because we've got good bone volume. We understand how to place the implant and our final result. So our problems come when we have bone volume which is now thin. What can we do with that? So now we have to go to bone grafting. So let's look at this scenario. We're going to lose a tooth. We've lost a tooth. We've got a triangular shape. We need a bone graft, so we've lost the tooth, a lot of bone resorption away. We're going to go and do a bone graft. Remember, when you do a bone graft and soft tissue graft, you will always get some resorption. You need to put a bigger graft in place than you'd ideally want, more soft tissue than you'd ideally want, and its healing is unpredictable. So we always need to be aware with bone grafting, we might get an unpredictable result. Remember that study by Priest? The least predictable aesthetic replacement is a single tooth implant. The least predictable single tooth implant aesthetic case is when we have to do grafting. So here we now have our implant in place. We have probably non-mature soft tissue. Again, we have triangular tooth. This happens to be a dentist. And he's got some pretty dark looking teeth here. We're going to do a custom made abutment, porcelain fused to metal custom made abutment, and we're trying to tie up the color of the adjacent teeth. So here's our porcelain fused to metal custom made abutments, going through that thin soft tissue we want the natural sort of root color. And here's our abutment in place, and there is our triangular tooth. Again, triangular tooth, we're missing our interdental papilla. This is where we started. There's our final result. Triangle, triangle, bone graft. Very difficult, almost impossible with a bone graft to recreate interdental papillae. Again, with our patient, because he's a dentist, he's quite happy with this particular appearance. Another bone graft case where, again, we've got not just loss of interdental papillae afterwards, but loss of vertical height. So our bone graft single tooth implant has gone into place. This is the end result that comes now for us to try to restore. And of course, the question is, and this can happen many times, even with the best of surgeons. Question now is, you've inherited this. You have said to the patient, okay, we'll put a single tooth implant in, we'll get a good looking result. I've got a great surgeon. The surgeon's come back and said, this is the best I can do. If the patient wants anything better, then we have to do multiple, maybe more than one further surgical operations. What are you now going to do? It's unpredictable, and that's the problem. So in these cases, sometimes we have to revert to pink porcelain. And in this particular instance, we're going to be using some pink porcelain to cover up the fact I've got some recession. And whilst it will be an okay result, it's never going to be as good as the patient's own tissue. And so we've put a prototype in as normal, trying to get that soft tissue to come down as much as possible by adjusting the sub-emergence profile again, making it flatter, allowing the soft tissue to fall down. And then once we've done that, we copy in the definitive. Here's my zirconia abutment. And now here is my gum margins at the same level with the white zirconia, but I've got the pink zirconia going up into the gum. And we're trying to match the pink zirconia around the gum margin with the patient's own zirconia. And fortunately, it looks a pretty good result, especially now at this level and this level. You cannot realistically see that there's too much going on. So with some pink porcelain, you can get yourself out of trouble. But that's another webinar, the use of pink porcelain, to try to get around these problems. So everybody, I hope that has given you some insight. I cannot tell you when to use partial denture, adhesive bridge, conventional bridge, implant. But I hope I've given you some planning criteria in terms of longevity, conservation, and aesthetics on how you would go about planning the case. Ultimately, the patient has to take responsibility. Ultimately, you advise, you do not dictate. Ultimately, you have to understand the literature and the science and have the skill set capable of delivering. You, yourself, and the rest of your team, not just you, your technician, your surgeon, your periodontist, have to have the skill set. You as prosthodontist, restorative dentist, general dentist, need to have the overall treatment planning picture. Remember, it's you and the patient who are going to decide between you which way you're going to go. So, hope that has been of some use to you. We're now going to open this up to questions, and I can see that we've got 18 questions already. So let's open it up, 19 questions, and we'll see what we've got. Okay, so I'm going to run through these one by one. Dr. Sakina, with regards to adhesive anterior bridge, is a double cantilever an option if the immediate abutment is mobile? Okay. Number one, we do not like double abutting. Okay, so we try to limit that, not use it wherever we can. Number two, when we do use double abutting, it is because the abutment, the original abutment that I might want to use, is too mobile. So in these cases, again, it's a clinical call between sometimes taking out a mobile abutment, extending the bridge. So this is what I talked about when we looked at bridge design generally. Plan from front to back. Choose your abutments. If you've got an abutment which is not a good one, contemplate, think about, plan for an alternative bridge, which may involve taking out a poor abutment rather than use it. And again, a mobile abutment may be called a poor abutment, and making the bridge longer. Your bridge will succeed better on better abutments. So I can't answer it definitively, but I hope I can give you a general treatment planning decision on when we do that. Anonymous, what cement do we use for cementing an adhesive bridge? Again, I don't want to particularly get into too much here on adhesive bridgework cementation techniques. I have an upcoming webinar next week, this time next week, where I'm doing Maryland bridges, and I will be going through everything about Maryland bridges, not just the planning, but also the cementation of them. Suffices to say that we have a different cementation regime for metal wings, for zirconia wings. For metal, it's Panavia. For zirconia, it's a little bit more complex than that. Anonymous. What cement? Okay, that's the same question which I hope I've just answered. We'll be looking at that next week. Which cement to use? Again, for RBB, Anonymous, we're using Panavia. Okay, so it's Panavia with a sandblasted metal base. What are the functions of zirconia and implants? Sorry, I don't really understand that question. What are the functions? The abutment is there. So we've got two types of restoring a single tooth implant. Okay, we can either go and do a screw retained, and that screw retained can be into an abutment, or it can be directly to the implant itself, or we can use an intermediate abutment. That intermediate abutment can be like a screw-in post, where we then cement a crown on top. And this is making single tooth implants much more like normal crown and bridge work. Or we can do a abutment, which screws into the implant, and then a crown which screws onto the abutment. My preference anteriorly as a prosthodontist is to use prosthodontic techniques. And therefore for me, anteriorly, different posteriorly. Anteriorly, I like to go cement retained. Posteriorly, I like to go screw retained. Azim, okay, how do you make gums go ovate? Is it only gingivectomy, crown lengthening, bone removal? Okay, so the ovate pontic, Azim, it's hugely important in aesthetic dentistry, bridge design, prosthodontics. We can do it one of probably three ways. Let's look at three ways. First way is if the tooth is still there, we take the tooth out, we then put something into the socket which is ovate, convex in nature, and the soft tissue will heal around it. Okay, that's the first way. Second way, if your tooth's already been extracted, we can do one of two things. Number one, we can get a burr and we can do gingival rotary curettage. That's much better than taking a knife to cut the gum away and then burring with a burr and then putting the soft tissue back away. So do a gingivectomy, gingival rotary curettage. If needs be, take a little bit of bone away, create the ovate pontic site, again, put a temporary back in place. So the soft tissue now heals around that ovate temporary. The third way is to let your technician do it. And what he does then is he takes the model with the convex ridge and he creates a small concavity in the ridge. Then that means that the pontic will have a small convexity. When you come to fit it, as in the case I showed you, initially it won't seat because the pontic is being held up on the soft tissue, but you have to get your patient to go and bite on a cotton wool roll for about 10 minutes. The pontic seats in, and then you can assess the marginal integrity. You can go and look at the occlusion. So those are the two ways, okay, or three ways. Number one, socket fill after extraction. Number two, gingival rotary curettage. Number three, cast scoring. You can do only a certain amount by cast scoring, because remember, you cannot go and drill 3 to 4 millimeters of bone of model away, because when you come to put the bridge in place, the tissue will not be able to compress that much. So the maximum you can do with tissue compression is in the region of about 2 millimeters. You can do as much as you want to with a burr. Okay, thanks for the lecture. What is your bonding protocol for zirconia adhesive bridges? Again, I'm going to go through that next time when we do adhesive bridge work. Joe, really enjoying the webinar, thank you. Just wondering, some of these studies are now 50 years old. There is nothing a little bit more recent. We've got recent studies in there, guys. Our recent studies go to 2013, 2017. So you have a mixture of some classic studies. Swartz 1970, still relevant today. Okay, up to Priest in the 1990s, Peterson 2008, Freiberg 2008. We've got some 2013. So it's important that we take a look at all, because some things don't change. Bridge design doesn't change. Materials change, some techniques change, but not everything. So we got a complete mixture in there, and deliberately we have a mixture of old and new. There's no point in just putting new literature in place. Old literature also stands the test of time, and you'll see a lot of the old literature being talked about more and more, and it's important that we have that nice blend. Dr. Sakina, can you advise on a good technician lab in Dubai? I'm sorry, I only know one lab in Dubai that we work with CAP. They're called MDent. They do all the work for us in Dubai. That's the only one I know, because that's the one I use. So if you want to go and work with them, by all means, tell them that I sent you, but MDent, and you'll get, you look at that. If for whatever reason you can't find them, drop me an email. My email is drpaultipton@gmail.com, and I will give you the name and address. Dr. Sakina, how do you provisionalize adhesive bridge preparations? First of all, sometimes they don't need it. So lowers don't need it because there's no chance of over eruption. So it's just the upper that we're worried about. And for that, then we put flowable composite in place. So it's a little bit like doing a temporary veneer. Place flowable composite, make sure the flowable composite goes over the incisal edge of your bridge abutment. It goes into the little grooves. It wraps around mesially. Okay, with a nice flowable composite, it's going to be fairly translucent, so it's not going to be visible. So you can really get good resistant retention form just by the shrinkage and then going into undercut areas. So that will stay in place. Azim, cement or screw retained implant abutments, what's my criteria? You could do a whole webinar on that, Azim. My criteria, as I mentioned towards the end, was posteriorly, where aesthetics do not matter as much, let's go for ease of retrievability. Anterior, where aesthetics matter more, I prefer to use standard crown and bridge techniques. That is where I will decide where the margin is, and I will put on a crown with a cement. And for that, I've got good longevity. I know my studies, we're going back to normal crown and bridge work. Sometimes it's impossible to go and do a screw retained. So with some of the cases where the implants are placed exactly where the teeth were placed, it means the access hole is coming out of the incisal edge. Yes, we can do angled abutments, but it makes life a lot more complex. So for me, simplicity at the front of the mouth, take an impression, work with your soft tissue, duplicate the soft tissue with a custom-made screw in post and core, and then a crown on top. Been doing it years and years, have a lot of knowledge, have a lot of experience of standard crown and bridge work at the front of the mouth. Azim, views on socket preservation technique. Yes, very good. Remember, Azim, I'm a prosthodontist. I am not an implant surgeon. I'm speaking from a prosthodontic point of view. If you want to know surgical techniques, please speak to a surgeon. Bipan, in an 85-year-old patient, what would you prefer to replace upper essentials, implants or bridge? Very easy, Bipan. The first thing I'll say to him is, how long are you going to live for? As soon as he gives me that amount of detail, he gives me a number, then I will advise him. Okay, obviously I'm being flippant here. We have no idea. If that 85 is in good health and he wants to live to his 100, okay, so we got 15 years. If he wants, and that will be, from my point of view, bridge and implants in the same realm. Does he want surgery or does he not? Does he want something a bit quicker? What's the time span? What's the aesthetics for that person? So there's criteria that we have to look at. I can't tell you what we'd do. I suppose if I would say it's on my grandmother, grandfather, I'd probably do the least invasive, and that would probably be a bridge, but I'm not sure. So too many criteria there. Sahel, thank you. Brilliant, Sahel. I'm glad you enjoyed it, Sahel. Thank you. Anna, can you explain again how you do gingival rotary curettage to create an orbit pontic site for adhesive bridge work, please? Yes, Anna, it is so easy. Okay, all you do is get a big round burr and you just drill up into the soft tissue and you create a concavity in that soft tissue. For a pontic, an ideal aesthetic pontic, you need that concavity to be around about 3 millimeters deep, ideally. And that's the reason why sometimes we don't just use the cast scoring technique, because with the cast scoring, we can get a maximum of 2 millimeters deep. So something a little bit more than that, we go to that gingival rotary curettage. Again, the tissue will bleed. That is not a problem. We will stop it bleeding by using astringent material. Okay, it's now stopped bleeding. What's really important is you put the right shaped prototype, temporary, now back in shape. Okay, and what that does, it stops the tissue from healing back to its original form. If you did nothing, it would come back to close to its original shape. So we have to do something which stops the tissue from coming back to its original shape. So the only way it can heal and your biologic width can come back is if we get bone resorption vertically. So that's the secret. Okay, surgery 5, thanks for a great presentation. Thank you very much, sir. Farhad, to plan an adhesive bridge to replace a canine, which tooth is better as an abutment? Not a great one to replace as a adhesive bridge for heel. Farhad, you would look obviously at the premolar behind it. You would have to make sure that that canine was not going to have any guidance whatsoever on it, have a light intercuspal holding contact. That would mean aesthetically that the canine may be shorter than the contralateral canine. So a very difficult aesthetic as well as functional longevity bridge to do. Okay, far better in those cases because the adhesive bridge would be unpredictable to either say to your patient, this is going to be unpredictable and therefore you take the risk, Mr. Patient, or move to something else that has a better longevity to it. And that might be a conventional fixed bridge, or it might be a single tooth implant. Hi, Shista. The single tooth approach is a conformative approach. That's got nothing to do with conformative or reorganized, Shista. So I don't really get that first question. Conformative or reorganized approach will be what's going on in the rest of the mouth. We're just looking at one single tooth here. Splints provided for all cases? No, I'll be providing splints for my cases where we've got TMD or we've got bruxing in place. With a lot of the single tooth implants, I like to protect the single tooth implants by not having guidance on them. So that means that my patient will not be able to grind and brux on a single tooth implant. So the same rules and regulations apply to the occlusion for single tooth implants as they do for pontics on bridge work. Okay, if possible. And if I cannot, for whatever reason, change the shape of it so my patient will be bruxing on it at night time, then that's when I will go and put a splint in place. Number 3, and some of the cases shown can see worn anteriors and loss of canine tips, with patients not keen to pursue any treatment for this. As you well know, Shista, patients will have done what they want to have done. Not all my patients come and lie down in front of me and say, do whatever you want to do, Paul, okay? I have exactly the same problems with your patients and everybody else. You'll advise to have something done, they say, just do this. So you just do that in the best possible way. Sorry, 4 off topic. 4-unit bridge, upper left 6 vital with MO amalgam, upper left 3 root filled. Is it fixed movable? Yes, as long as, so I would go for a fixed movable in that situation. Takes a little bit of stress off the canine. However, I would like that patient to wear a splint because I don't want the patient to have canine guidance. Don't want the patient to have premolar guidance on the Pontics either. So that will be a splint. And it's all, that advice is with the fact that the patient has got reasonable ferrule on that canine. If there's no ferrule on the canine, forget it. It's not going to work. Anonymous, okay. Can we create locate Pontic, ovate Pontic using immediate denture replacement at a specific shape? Yes, you can. Very important. And it's, thank you for saying that. Another way of creating the ovate Pontic, it takes a lot longer, but is to put a gum-fitted partial denture in place. Okay, mucosal borne, simple gum-fitted partial denture. What will happen? As you know, over a period of time, the partial denture will start to dig into the gum. It will create its own ovate Pontic shape. You may need to reline it. That's the tooth part again, so it digs in a bit more and a bit more, but eventually it will create a lovely ovate Pontic shape. That might take 6 months. Doing with the drill, gingival rotary curettage, will take 6 minutes. But both of them will give you a good result. Shaista, thank you. I hope you enjoyed it. My pleasure. Tell everybody how good they are. Neha, okay, ovate Pontic, I've got you. Anonymous, thanks for your lecture. How did you securely place the prototype in the immediately placed implant one on your cases? That was just a temporary cement. So temporary cement on a screw retained abutment, and I can easily pull with the temporary cement. This was temp bond. Temp bond, I usually put a little bit of Vaseline in it as well, and a direct pull down, not trying to rotate it side to side, but a pull down. So use forceps, put forceps on the temporary, just pull down, and that breaks the temp bond. Very, very simple, very, very easy. Azim, fixed movable bridge design can be done for lower posteriors, or is it only for uppers? No, Azim. Okay, go and watch my bridge webinars. Okay, I've done 4 hours of bridge webinars on bridge design. Okay, it's done for lowers and uppers. Okay, both of them. Anonymous, how did you also ensure the contour of the prototypes is correct for the immediate implant, so gingival tissue can be properly shaped for good emergence profile? With the immediate, obviously it is a little bit suck it and see. It is experimental. We try it. Okay, there's no way that I can take that prototype on and off during the healing phase. Okay, but what I can do as 4 months, take the prototype off and start to change the profile. And as long as at 4 months I'm changing the profile, we're going to get the same result. So it doesn't matter if I'm changing the profile immediately or 3, 4, 5, 6 months, 12 months later. Okay, the tissue will respond to the sub-emergence profile of your temporary restoration. Okay, Azim, thank you for clear answers. My pleasure, Azim. Laurie, okay, thanks for a great webinar. When replacing an anterior tooth with an unrestored abutment tooth with favorable occlusion, why would you not try a no prep cantilever in the first instance? Purely because, Laurie, the success rates with no prep versus a little bit of prep, they're just not as good. So why would I try something that I know will not be as good? And then two things happen. Number one, if it does fail, I have to re-cement it. That's more time for me. Patient, that's a bit of a drag for the patient. I have to re-cement it a second time, possibly. My patient then is saying, is this going to happen on a regular basis? Starts to doubt me. So we have to have that conversation again. And that conversation I'm always having with my patients, okay? We've got three things that we need to get out of the restoration. And you need to have this conversation every single time you do a restoration, especially a restoration where the patient is paying a reasonable amount of money. So that's a crown, veneer, implant, bridge, whatever it is, okay? And the conversation goes like this. We have three major criteria that you need to know about. Longevity, we need to discuss how long this is going to last and the success rates. We need to discuss how much tooth tissue, if any, we take away to get that result. And we need to discuss aesthetics. And I'm going to tell you now, Laurie, and I'd love to be proved wrong, there is no restoration you can do that has the best outcome in terms of aesthetics, longevity, and minimum tooth prep. So our patient has to choose which are the most important two. And if it's an adhesive bridge, and he says, absolutely, I am not having any tooth preparation. Fine, let's go and do your Maryland bridge without any tooth preparation. You have to realize, Mr. Patient, you've made that choice. The choice therefore means that the success rates will not be as good. So if this comes uncemented, then that is down to you. I will charge you when it comes uncemented. The patient then says, oh, I don't want it to become uncemented. Okay, let me do a little bit of tooth preparation then. So that's how the conversation goes. And eventually you come to a conclusion. You put that conclusion down in writing with the whys and wherefores. The patient signs it, and then that is consent. So, Laurie, I hope that answers your question in a roundabout way. Brindusa, thank you very much. Very good explanations. Best teacher in the world. Brindusa, that is a wonderful thing to say to me. I'm sure I'm not the best teacher in the world, but it would help me tremendously if you went out and told the world on Facebook and Instagram that I am. Thank you very much indeed. Azim, if it's the last standing tooth in the arch and required as an abutment, can we prepare for a bridge abutment without disturbing the occlusal stop? Oh, that's a good one. Can you? The answer to that is no. Realistically, work around it. You've got good prosthodontic techniques where you can get stabilized occlusion and occlusal registration. So work around it. Just because it's the last occlusal stop, for me, would not mean I have to work any differently. So answer is no. Learn the prosthodontic techniques for making good, decent jaw registrations. And that means that you're working around RAP, so you can do an RAP registration. So reorganized approach. Neha, best option to replace lower 6 cantilever or fixed bridge. Thank you very much for your information. Neha, without seeing anything that's going on around it, the opposing teeth, the adjacent teeth, bone loss, periapicals, etc., the best way to replace a lower 6 is a fixed movable bridge between the 5 and the 7. Not cantilever off the 7, not a fixed. Now that doesn't mean to say that sometimes we would not do a cantilever off the 7. Doesn't mean to say we'd not do a fixed. But in terms of longevity, on average over the whole population, you'll get better success rates if you use a fixed movable more predictably, more times out of 10 than if you use the other two. I'm quite happy if you email me the case, I'll give you some direct advice. Fatima, after gingival rotary curettage, could you please repeat how to prevent gums coming back? Yeah. So we take the gum away. The gum's got a great propensity to grow back. So it will come back to its near original position. So we have to stop it. The only way we can stop it is to put something there in place that will not allow the gum to go back. Okay, because what the gum is trying to do is, if you've done a gingival rotary curettage and you've gone through the soft tissue, periosteum, you've just taken a little bit of bone away. Our body's response is that bone cannot be on show in the mouth. We need a biological width. Bone has to have periosteum on top of it. Periosteum has to have connective tissue on top of it. Connective tissue has to have epithelium on top of it. If you prevent the soft tissue coming back down by putting a prototype or temporary bridge pontic in place, the only way that our body can replace and have the correct biologic width is for the bone to resorb, and that's what you want to happen. So it's a direct pontic that goes in place, okay? And that can be an adhesive bridge pontic, it can be a conventional bridge pontic. PT, excellent webinar. PT, I wonder who that is. That's me, PT. Okay, what's the next one? Fatima, really informative, learned new techniques. Thank you, excellent. Mariam, in a case where we need to replace lower anterior foreteeth, okay, 4 incisors, will we consider a Maryland bridge? Is this a case when the restoration on the canine? Okay, so doing a bridge for those, it's either adhesive or conventional. If we are going to do conventional, then we need to make sure we're doing the maximum tooth preparation. That's guide planes, that's mesial and distal grooves on both teeth, those are SEs. The difficulty of doing that preparation, and that is a difficult prep, okay? We do that prep on our Phantom Head course. So if you want to learn how to do it, come on our Phantom Head course. We do that preparation. We show people, but that's a difficult prep. Much more difficult than doing a conventional crown prep. So you have to understand not only which is the best one for me or a prosthodontist to do, but what's within your capability. I do not know your capability. But if you don't do a Maryland bridge preparation really well, it's going to fail. It's of no use. So if you don't have that skill set, number one, learn the skill set, come on the courses, or number two, go to a conventional where you know it's going to work. Or if the patient says, I don't want my teeth cut down, think about 2 implants in the lateral incisor regions and a 4-unit bridge. Okay, Anonymous. Excellent presentation, Prof. Thank you. If 2 teeth are missing in the anterior region, for example, central lower incisors, and abutment teeth on either side of the gap present with mobility, when using an adhesive bridge, is advisable a fixed design with more than 2 retainers, or better to use 2 single retainers. Okay, so we've got 2 lower central incisors missing. We've got mobility on the 2 laterals. First of all, test it out. Splint both laterals together. Okay, so go and take a couple of pontics. Maybe do this in composite. Just splint them together. Once you've splinted them together, see how much mobility there is. If the patient is accepting that amount of mobility in that it doesn't cause him a problem when he's chewing. If you can control further bone loss, then do a 4-unit bridge using both laterals as your abutments. If then there's too much mobility, take the laterals out and go for a 6-unit bridge, canine to canine. Do not double abut mobile tooth with strong tooth, especially in a Maryland. So don't do what you're thinking about doing, which is putting the double abutting lateral and canine together, lateral and canine together for a 6-unit bridge. No, it's either a 4-unit bridge using both laterals, or you take the laterals out and go for a 6-unit bridge. Okay, now what I'm talking about when I'm saying that is longevity. Okay, you can of course do anything if the patient accepts the risk, but what we're talking about is longevity. And my problem I have with using the lateral and the canine together is that usually the cement fails on the strong tooth. Doesn't fail on the mobile one, okay, it fails on the strong tooth. So now you've got a situation where you've got caries on the canine, and I showed that picture early on I showed exactly that, where we had a lateral incisor and a canine double abutted. The canine failed and you had caries. Fortunately, not one of my cases. Okay, next question. Where are we now? Thank you very much. Dr. Sakina, for an upper anterior adhesive bridge, do you usually use Dahl techniques to allow the patient to reestablish occlusion, or is there another way? I did a webinar on the Dahl technique yesterday. I don't know if you caught that or not. The problem with doing a conventional adhesive, sorry, a cantilever adhesive bridge and use the Dahl technique is you're not splinting teeth together, and therefore the tooth may just decide to go labially. So if you're going to use the Dahl technique, you have to do one of two things. Number one is use a temporary adhesive bridge with multiple wings, get the intrusion, and then change it for a cantilever bridge and let the teeth that you've intruded over it. Or number two, put the design a fixed adhesive bridge, put it on with glass ionomer, now get the intrusion, Dahl appliance effect. Once you've done that, take the bridge off, cut one of the wings off it, and now go and cement it in place. And again, allow the other tooth opposing the wing you've cut off to over-erupt. So that would be the way I'd use as a Dahl appliance. Now, if it was a fixed adhesive bridge, yes, by all means, put it in high because you're splinting the teeth together. Okay, next one, Selena. Are your previous bridge webinars available, or is it just Tipton subscribers, existing delegates? It depends when it was. Selena, we have them available for everybody for a week. We can at a push make it maybe 7 up to 10 days, but otherwise they are just for my delegates who are paying cash, paying money to listen to me do this. Also, they will be at the end of the month when we're stopping the webinars, we're winding down. Everything is going to be put onto the BARD website. And one of the ways of seeing these would be to just become a BARD member, pay a monthly subscription, and then you can get all of these webinars. Mariam, well, I think we've done that. Okay. Anonymous, yes, we've done that one. Okay, in a post-orthodontic case with missing maxillary laterals, would you ever recommend fixed adhesive bridges to act as fixed retainer? No, I don't like that idea at all. I'd be more likely to probably split the two centrals together with a little bit of wire and composite, and then have a Maryland 2 cantilevered off the 3. Yeah, that's what I'd do. Excellent presentation, Prof. We've done that one. Okay, guys. 44 questions. Anybody has a last minute one, please pop it down because we're going to be finishing now. If you don't have any questions, then we're going to call it quits. But if you do have any final questions, get typing now. I'll give you 1 more minute to type something out. Otherwise, it's 12 o'clock. We've had 2 hours. Hope you've enjoyed it. Please tell people if you found it enjoyable. Please tell people about it, and we'd be very happy to have more and more people attending these webinars.